I have the pleasure to introduce Dr. Tara Freibel-Klingner, and we've interacted because we have research interests, but mainly by Zoom, as we all do these days. But Dr. Freibel-Klingner is an epidemiologist with research interests focused on cancer epidemiology and global health, and specifically cancer prevention and early detection in low resource settings. She's currently a postdoctoral fellow in cancer epidemiology at Johns Hopkins Bloomberg School of Public Health, and her current work focuses on prevention and early detection of women's cancers in low income settings. With additional training, she also has implementation science and qualitative methods that she applies to her research. Her work is focused on identifying demographic, clinical, and geographic features of cervical cancer patients in Botswana and on improving breast cancer care pathways in Tanzania. So without further ado, Tara, can you take over and say hello to our group, and please start your presentation.
Yes, thank you so much, Dr. Marlink. It's nice to see all of you. I have met some of you in person, but not everyone. So hello to everybody. I will pull up my presentation.
Great.
Okay, so I'm assuming everybody can see. So thank you all. I'm very excited to be able to talk with you all today regarding recent work that I've been doing related to epidemiology and implementation for cancer control in Sub-Saharan Africa. Right, for the next for the next 30 minutes or so, I'm going to talk quickly about my education and training, a bit of background and motivating factors for the work that I do, and then for a couple specific projects regarding cervical cancer in Botswana, breast cancer in Tanzania, and then integrated cancer control. So in 2000, I received my MPH from Johns Hopkins Bloomberg School of Public Health. For the next almost 2 decades, I was a project manager managing a number of epidemiological studies, mainly with Dr. Timothy Rebick. First, I was at Perelman School of Medicine, and then at the Dana-Farber Cancer Institute. And I was part of a lot of, I managed and collaborated with a number of national and international consortiums. The prostate cancer study in Senegal, known as Progress, breast cancer prevention study, and a consortium for the international modifiers of BRCA1 and 2, known as SIMBA. So most of my work revolved around looking at risk factors and mortality data for women carrying BRCA1 and 2 mutations. And we looked, as I mentioned, at risk factors, mortality, and genetics as well. And so one of my first projects was actually the prostate cancer study in Senegal. And then one of my last projects kind of took me back to Africa, where I looked at BRCA1 and 2 variants in women of African origin. And so a little bit of background. I just wanted to talk about the global burden of breast and cervical cancer. So as we can see, breast and cervical cancer are the #1 cause of mortality for most of Sub-Saharan Africa, if not all. As opposed to countries like the United States and Australia, cervical and breast cancer are the #1 causes of mortality, and this is mainly driven by cervical cancer mortality. And so there are large disparities in cervical cancer mortality. As we all know, cervical cancer is a malignancy of the female reproductive system. It's caused by the human papillomavirus. It's preventable through the HPV vaccine or HPV screening, and it's also curable with early detection or screening and appropriate treatment at early stages. Because cervical cancer is both preventable and curable, the World Health Organization has set forth an initiative to eliminate cervical cancer by 2030. But looking at this map, we can see that the majority of cervical cancer deaths, or over 85%, occur in low resource settings. So the age standardized mortality in sub-Saharan Africa is almost 10 times what it is in somewhere like the United States. And so this large disparity in mortality is mostly driven by late stage of diagnosis. So we can see from this graph that survival is much lower when you're diagnosed at later stages, stage 3 or stage 4, as opposed to earlier stages. And this late stage of diagnosis is the main contributing factor for this higher mortality in sub-Saharan Africa. And later stages of diagnosis are in part because of barriers in access to health services. So barriers can cause a delay in presentation, and this can result in the progression of a malignant tumor to a later stage where the mortality rates are higher. And as we can see from this figure, barriers are very complex and involve numerous individual and health level system factors. And so barriers can consist of geographic location, financial costs, the ability to understand what we're doing, transparency and outreach, just to name a few. And so, you know, the motivating factors of why I am doing this work is because cancer is a critical public health issue in sub-Saharan Africa. As the demographics are changing in Africa and as people are living longer, cancer is also a growing public health issue. One of my main motivations is that women are dying from a preventable, incurable disease because they cannot access care. And yesterday I received, I just opened an email from Japigo, and it just happened to be this one. And it really, you know, was exactly what I was thinking about. And the sentence really resonated with me of where you live should not determine if you live. And so in order to, you know, have an impact on cancer mortality, we need epidemiologic data. And so there is a lack of epidemiological data and studies on cancer stage and mortality in sub-Saharan Africa. And it's hard to measure progress knowing if we're decreasing mortality or understanding risk factors without this data. And so data that we can get from our studies can also help us guide interventions, policy, and resources, all aimed at decreasing the cancer mortality. And so I'm going to spend the next few minutes talking about cervical cancer in Botswana. This was my dissertation work funded by an F31. I was a PhD student in epidemiology from 2018 to 2021. And so Botswana, as I'm sure all of you know, it's an upper middle income country in sub-Saharan Africa. It has about 2 million people. It's actually a pretty sparsely populated country, and they have government funded healthcare. So the government is very involved in helping people get their diagnostics and treatments for cancer. Botswana also has the 3rd highest HIV prevalence globally. So over 20% of the population is living with HIV and AIDS. And this is important because cervical cancer risk is 6 times higher in women living with HIV. And this figure shows us that cervical cancer is the #1 cause of cancer in females in Botswana, and it's also the #1 cause of death. And so in 2020, Globocam estimated approximately 374 cervical cancer cases and 207 cervical cancer deaths for Botswana. And so thinking about the health services in Botswana, in 2015, as part of the HIV care continuum, Botswana implemented a national cervical cancer screening program. In the same year, the Botswana UPEM partnership that had been working in Botswana for almost 2 decades, helping battle the fight against HIV, established a multidisciplinary gynecological oncology team clinic led by Dr. Cervical. They had seen an uptake in women with cervical cancer coming to their hospital, and so they decided to establish this clinic. It's located in Princess Marina Hospital in the capital city of Gaborone. And it's these patients that are both at Princess Marina Hospital and Haveroni Private Hospital, which are the two referral hospitals in Haveroni, and they're only about 2 kilometers away from each other. This clinic sees about 200 cervical cancer cases per year. And it's important because it's the only chemoradiation facility in the country that provides a standard of care for the majority of cervical cancer cases. And in the literature, when I was looking at this problem, we noticed that there's really a lack of data and understanding associations with late stage or later stage of cervical cancer at diagnosis in Botswana. And so the conceptual framework of my dissertation, looking at the epidemiology of cervical cancer in Botswana, first, we decided to look at individual risk factors. So things like HIV, marital status and age, health facility level factors like screening, and then the stage that they were presented with at the clinic. So individual factors that were associated with late stage of diagnosis. We also wanted to look at the geographic distribution of the cancers and the women presenting from around Botswana. And we also wanted to look at travel time, which is one component of access to healthcare services and its association with stage of diagnosis. And so our cervical cancer cohort comprised women that were presented to the MDT clinic between 2015 and 2020. It consisted of almost 1,000 women. We defined late stage as stage 3 or 4 versus early stage, which is stage 1 or 2. About 45% of the patients presented with late stage disease. Almost 70% of the women were living with HIV. 40% of the women reported never being screened. But we also noticed that 73% of the women reported abnormal vaginal bleeding. So of the proportion that were screened, it seems that it was probably not asymptomatic screening. And so the individual characteristics that we found that were associated with late stage cancer is we noticed that cervical cancer screening was protective against presenting with late stage cancer, which we would expect. And it's evidence that cervical cancer screening is effective in this population. But we also found that abnormal vaginal bleeding was associated with an increased risk of presenting with late stage disease, as we would expect. And then we wanted to look at it by HIV positive and HIV negative women. And so we also saw the protection of cervical cancer screening with late stage disease in our women living with HIV, but we did not see this protection with women that did not have HIV. We also did see an increased risk of presenting with late stage disease for abnormal vaginal bleeding, but the risk was actually higher in women who did not have HIV compared to women who had HIV. And then we wanted to look at the geographical distribution. So we wanted to kind of look at the patterns of the women that were presenting to care at this MDT clinic. We decided to define a presentation rate. We define this as the number of presenting cervical cancer cases per subdistrict, divided by the subdistrict population of women aged 20 plus. And so we can see from this map that the presentation rates were not necessarily random throughout the country, but in fact, they tended to be clustered. And this was confirmed by the global Moran's-I, which was positive, which shows that there is kind of a non-random clustered distribution throughout Botswana. And we also noticed we wanted to look at the overall presentation rate and some association with community level factors. And we did not see an association with HIV or the population density, but we did see an association, an inverse association with travel distance and the presentation rate. And so looking a little bit closer at these patterns of cervical cancer presentation, we did note that there were some clusters in the Northwest that were determined to be low clusters, meaning they had low presentation rates. And then there was a high cluster in the South. And these presentation rates of being high and low were kind of indicating perhaps differential access to cancer care. And then lastly, we looked at travel time and cancer stage at presentation. And so again, we see the map of Botswana, and we categorize travel time into 5 different categories. And we can see that the majority of Botswana live about, well, sorry, that's not true. So about 50% of Botswana lives over 3 hours away. If you remember in the beginning, there was a slide with the population density, and the majority of the population does live around Gaborone, but there is also a large proportion of the population that lives in the rural areas throughout Botswana. So about 50% of the population we found lives more than 3 hours away from the clinic. And we did see an association with later stage of diagnosis. So women who lived 3 or 5 hours away had a 2-fold risk of presenting with stage 2 disease versus stage 1 disease. And women who lived 3 to 5 hours away also had a 4-fold increased risk of presenting with stage 4 disease versus stage 1 disease. And so lastly, we wanted to see if HIV status was influencing the access to care. And this one graph shows us that the prevalence of women living with HIV, so the yellow line, that's about 20% throughout all the travel time categories, is showing us the prevalence, and it remains constant throughout. But we can see that the proportion of women that had HIV differed throughout. And as a matter of fact, the women who lived over 5 hours away were more likely to be HIV positive than HIV negative. And we tend to think this could be an access issue because the prevalence of HIV was the same. We would think it's more of an access issue as opposed to a biological etiology. And so just to kind of summarize everything, we learned that cervical cancer screening was associated with early stage cervical cancer, particularly in women with HIV. As we would hope and expect. Abnormal vaginal bleeding was associated with late stage cancer, and this association was greater in women without HIV. We also saw a non-random clustered distribution of presentation rates. So not all women potentially with cervical cancer are presenting equally for staging and treatment. We saw subdistricts with disproportionately high and low presentation rates. And so it lends us to think subdistricts with low rates may have poor access and subdistricts with high rates may have better access. And this was also further supported by the inverse association we saw with travel time and presentation rates. And lastly, we saw an increased odds of presenting with stage 2 or 4 disease versus stage 1 disease if the woman lived over 3 hours away from the clinic. And the association with HIV status may also be influencing access to screening and treatment. It's possible that women and healthcare providers, because cervical cancer screening was implemented as part of the HIV care continuum, and because the risk is so much higher in women living with HIV, it's possible that women and healthcare providers are unaware of the need to screen for cervical cancer in women without HIV, or not understanding that the risk is high enough that they are presenting for screening. And so what can we do? We can prioritize collection of population-based cancer incidence and mortality data. As we can see from the picture on the right, most data for Sub-Saharan African countries are estimates. And so this information is from the Botswana National Cancer Registry, and for mortality, it states that there is no data and it's estimated from neighboring countries. And this is the case for a number of Sub-Saharan African countries. We can include women without HIV in cervical cancer awareness, prevention, and screening efforts. We can emphasize cancer symptom awareness. So particularly abnormal vaginal bleeding and the urgency to get to care for the risk of cervical cancer. We can investigate additional barriers in access to screening, diagnostics, and treatment. As I mentioned, there are a lot of different aspects of accessibility, and they're all important in accessing care. And then we can also prioritize implementing cancer control evidence-based interventions. So things like prevention and screening. So evidence-based interventions, specifically cancer prevention, screening, and early detection, they're recognized as the most effective approaches for cancer control, and they're associated with reduced cancer incidence and mortality. And we've seen this in the United States because cervical cancer mortality has been reduced 70% in the past 70 years due to the implementation of cervical cancer interventions. And so in order to see this disparity in mortality decrease, we need to implement evidence-based interventions to scale in Sub-Saharan Africa. But there is this translational research gap. We know that these evidence-based interventions work. We know how they work, but they're just not into practice. And that mainly comes down to that evidence-based interventions are not one size fits all. Some things that work in some countries might not work in a different country. For example, we have mammograms in the United States, but mammograms aren't really used in Sub-Saharan Africa. Clinical breast exams are used in place of it. And so we really need to look at the country and the context and understand what are the barriers for this specific intervention in this specific community. And so this led me to want to learn more about implementation science. So as part of my doctoral program, one of the, it was introduced in one of my courses, and it just seemed like a missing link, if you will, to what I've been studying all along. And so implementation science is a study of methods to promote the systematic uptake of research findings into evidence-based practice and improve the quality and effectiveness of health services. So implementation science is really meant to bridge this translational research gap. And it's meant to get these evidence-based interventions into practice, into healthcare services sooner and more effectively. We can use implementation science to understand contextual relevance and address inequities. Inequities in access in particular, because we can ask the question, can everyone access the care that they need? Because we can see that disparities in breast and cervical cancer mortality are caused by a number of inequities and inequities in access. And equity, as we all know, is not a one-size-fits-all either. So different countries have different needs, and these needs and implementations might look different for different places. And so implementation science provides us a toolbox of theories, models, and frameworks to bring these evidence-based interventions into real-world settings in order to improve health outcomes. And so they consist of process models, determinant frameworks, implementation theories, and then there's also evaluating implementation outcomes. And these are kind of intermediate outcomes because, before we see a downstaging of cervical cancer in the community that we're working in, we can test the effectiveness or the feasibility or even the acceptability of the implementation that we are, or of the intervention that we are implementing to see if it's going to work and hopefully eventually see the downstaging of cancers. So my desire to understand more about implementation science actually took me to my postdoctoral training with Dr. Ann Rossich at the Johns Hopkins Bloomberg School of Public Health, where I'm on the T32 Cancer Epidemiology Prevention and Control Training Grant, and working on a study that's looking at breast cancer in Tanzania. And so Tanzania, it's a lower middle income country in Sub-Saharan Africa, It has a much larger population than Botswana of 58 million people, but disparities in cancer mortality persist. So 5-year survival for a woman diagnosed with breast cancer in Tanzania is about 45%, where in the United States, someone who's diagnosed with breast cancer, 5-year survival is about 90%. And again, this is driven by, sorry, is there a question?
No, I just went off mute. As before, just to jump in about HPV vaccination, maybe we can touch on that after during the question and answer period for how that comes to play in Botswana.
Yes.
Coverage and those things is obviously would help prevent cervical cancer.
Absolutely. Yep. So we can talk on that in a little bit. And then actually it could, potentially be part of the integrated cancer control that I'll talk about in a couple minutes. But we also note that the disparities in breast cancer mortality in Tanzania are also driven by late stage of diagnosis. And so in Tanzania, approximately 80% of breast cancers are diagnosed at advanced stages. And so my mentor, Dr. Ann Rosich, implemented a time to act study. And this study is, if you can see in the figure, it's implemented into or at Bugando Medical Center, which is a zonal hospital in Mwanza, Tanzania. So Mwanza is in the north of Tanzania. It's also sometimes referred to as the Lake region because it's on Lake Victoria, and it serves about 10 million people. And this time to act study had 3 components of assess, couple, and test. And so this is an implementation science study, kind of using all the components of implementation science that we need to understand the contextual relevance of the country. And so the first part of the time to act study was to assess the situation. So they have a paper published doing a retrospective analysis of the landscape assessment of breast cancer treatment to date in order to prepare for implementing new standardized treatment guidelines. And then they coupled with the stakeholders at the hospital and all the important stakeholders for the breast cancer care pathway, and really worked with them to understand what are the barriers, what do we need, what will help this hospital the best, what can we do, what can't we do, and kind of really worked. Implementation science is really working together with the people on the ground to implement the best intervention that can be effective. And then the T for time to act is to test. And then you test and you repeat. You see how you're doing, and you may need to modify along the way. And so really the time to act study, its aim is to reduce breast cancer morbidity and mortality through creating, implementing, and monitoring standardized care and treatment pathways. And so this is the conceptual model for the time to act study. And I'll just talk about it really quickly, but it's a multi-component study. And as I mentioned, they really worked with the stakeholders to come up with this plan. The first component was to coordinate the flow of patients arriving at Bugando. So they did do an intervention of clinical breast exam training for the staff and help streamline referral pathways. So if a woman came in with a breast concern, she had a proper clinical breast exam done, and then the proper follow-up. The second component was to focus on improving diagnostic pathway and imaging. And so we're really trying to get the women through as seamlessly and as quickly as possible. And then the third component was to focus on a comprehensive treatment planning and diagnostics. And so they created a multidisciplinary breast cancer specific tumor ward that gets together and talks about the patients and patients that have been diagnosed with breast cancer and what their treatments will be. And so the time to act prospective cohort, it started in August 1st of 2019. And the data I am showing is through January 31st, 2022. They have, at that time, 920 women with a median age of 44 years old. About 50% of the population does not have health insurance or did not report having health insurance. Unlike Botswana, there is not government-funded health care here, and women really need to pay out of pocket for most things. And so of all the women that were given a clinical breast exam or clinical breast assessment, 30% were determined to be benign and they were treated. The other 70% were either suspected of having a malignancy, or the healthcare staff, the physician, really wasn't sure. And so they, for our purposes, continued on the breast cancer care pathway because they were still potentially at risk of having breast cancer. And of this total cohort, 24% were diagnosed with breast cancer. Almost 60% were diagnosed with a benign breast condition. And then almost 18% of women were actually lost during this follow-up period. And so they were on the breast cancer pathway, but they did not finish the diagnostics or return. And so we cannot confirm their diagnosis. But of the women that were diagnosed with breast cancer, we did see almost 70% initiated some sort of surgery or chemotherapy for treatment for their cancer. But we also saw that 70 women, or 69 women, or about 30%, did not initiate any form of treatment. And so we wanted to look at the geospatial access barrier for women that are presenting with breast concerns to BMC. Again, like we did in Botswana, we looked at the presentation rate, or the number of patients with breast cancer over the at-risk female population. And this map is showing the 8 regions that are around Bugando, and the star is where Bugando is. And we can see that the presentation rates of breast cancer are, as we saw before, very low. Ones that have the highest rate of 3 per 100,000 women, but most of the rates were much lower than that. And so another aspect we wanted to look at for the Time to Act project was to evaluate the ACT intervention that was meant to improve the breast cancer care pathway. And in a country with lower resources, it's beneficial to identify, the kind of the step along the pathway where there are the biggest losses that occur in the care. And so we decided to apply a cascade analysis to the breast cancer care pathway. And we identified 5 cascade steps, beginning with the initial consultation of a clinical breast assessment, all the way through the cancer treatment. And so our first step, we determined to be the clinical breast assessment. Anyone who was suspicious of malignancy or inconclusive continued on the pathway. Step 2, we defined as having a diagnostic test ordered for the breast concern. Step 3 was defined as having that diagnostic test done. Step 4 was defined as completing all of your diagnostics and having a final diagnosis. And then the women who were benign were removed from the pathway, and the women diagnosed with breast cancer continued on to step 5, where is initiating cancer treatment. And so this is the data we had for our breast cancer care cascade analysis from Bugando. And we could see that we had high percentage rates for diagnostics. So 90 to 95% of women completed step 2 and step 3 and step 4. Of the women that were diagnosed with breast cancer, however, only 70% initiated treatment. And so this was the step 5, that we had the biggest loss. And so in a country with limited resources, to identify the step that if we invested our resources in this step and fixed it, where could we, help the greatest number of women? And so this cascade analysis showed us that that is step 5. And so fixing this would have the biggest impact on improving breast cancer outcomes. This data is also going to be used to inform a new patient navigation program at Bugando, which will help women kind of get through, their breast cancer diagnostics, and also really encourage them to initiate treatment, follow up with them, and make sure that some sort of treatment is started. And then this program, this evaluation, we feel is pretty helpful for the physicians, for the hospital to look at, and it's something that can be kind of continuously done over the years to kind of reassess, which steps are we doing well at and which steps need some improvement. And so, lastly, I just want to talk about some additional work that I'm doing. So we do want to do a formal evaluation of the intervention for the Time to Act study, and a formal evaluation of the treatment pathways pre and post intervention. But the intervention was introduced in February of 2020. And as we all know, COVID-19 happened really in March of 2020, and pretty much disrupted health services across the globe. So, we're taking careful time and consideration to kind of look at this interrupted time series analysis for pre and post intervention, with the caveat that there was COVID-19. As I mentioned previously, to really have an impact on cancer mortality, we really need to scale up cancer control interventions in low to middle income countries, because that's where the majority of the mortality is taking place, particularly for these preventable and curable diseases. And so we actually are conducting a scoping review to understand the state of the science for scale-up of cancer control interventions. This is it's a literature review looking at the number of scale-ups that are occurring. We have found 24 studies, 50% which are in Africa. And we ourselves are applying an implementation science lens to kind of look at these studies and identify what implementation strategies are being used and what implementation outcomes are being measured for these scale-ups to be successful. And we can see, as we would probably expect, that the large majority of these scale-ups are focused on cervical cancer. A couple are breast cancer, but the majority are cervical cancer. And then another project that I'm working on, which is another, I feel, really important aspect of cancer control, is Johns Hopkins has a P50 cervical cancer score, and we submitted a supplement to try to understand recruitment and retention for clinical trials in Nigeria. So really that the vaccines that we're using for cervical cancer, the treatments that we're using, are really applicable to the population. And so many of us know that clinical trials tend to be in high-income countries, and for it to really be applicable to the population that we want to use it in, we really need that population to be part of our clinical trials. And so we really kind of we're currently working with our team in Nigeria to understand barriers to recruitment or retention. And then for future research, so the things that I want to do, that I think, after looking at all this information, that are important to do, is integrated cancer control. And so in Tanzania, we talked about breast cancer, but cervical cancer also has very low screening rates. And in resource-limited settings, it seems to make sense to initiate a single visit approach or integrated cancer control, where we offer concurrent clinical breast assessment and either visual inspection with acetic acid, PAP tests, or HPV self-testing, whatever is appropriate for the community we're looking in. And to take some of the burden off of the tertiary care facilities, we want to decentralize the evidence-based interventions to primary healthcare facilities. To do this, we want to determine, the optimal population that we want to serve. And also, I think it would be important to build on existing infrastructure. And so just as the cervical cancer program in Tanzania kind of built on the HIV program, these integrated cancer control measures can be built into existing primary care infrastructure, as we are doing in a project in Rwanda with Lydia Pace that is looking at integrating breast cancer early diagnosis into primary healthcare in Rwanda. And I'm sorry, I know I'm running a little bit long. So I'll try to talk about this really quickly, but we have really thought through about implementing integrated cancer control measures in Tanzania. And so I submitted a K99 R00 using mixed method approaches, so implementation science, qualitative assessment, and quantitative assessment to really understand the best way to implement integrated cancer control and the best way to carry it out. And so we propose this method that's adapted from the INSPIRE method. It's actually adapted implementation science method meant to facilitate the global elimination of cervical cancer. And so as I talked about with implementation science, the first steps are to really understand the situation. So talk with the stakeholders, do primary care health surveys to see what infrastructure and resources already exist. Then we want to find leverage. So we can do focus groups, in-depth interviews to really assess the barriers that we are running into in these populations. We can talk to healthcare workers, cancer patients, at-risk women. We can really focus on the barriers, and then we can also prioritize the barriers. So for our next step, we can develop whatever materials we need in order to implement this integrated cancer control. We may need resources, we may need educational materials, we may prioritize community outreach. It really depends on what we learn from AIM 1, what we would do in AIM 2. And then for future R00, we will want to implement this integrated cancer control in health centers in Mwanza. Eventually, it would be great to scale up to all 8 regions in the Lake region of Tanzania, and then of course to scale up across Tanzania. And so I will end with the future work that I want to do and its impact. So really, to have an impact, we would want to scale up this integrated cancer control to regional and national levels. And as you probably all know by now from implementation science, it's all about understanding the context. And so this integrated cancer control that we proposed can really be the reason why I have it written here with kind of early detection measures in blank. It can be any population. So we can really kind of adapt this framework to fit Botswana or fit New Jersey. So just to understand the context of whatever population we are in. And then, of course, as my epidemiologist hat that I also wear, we really want to collect data to be able to investigate the risk factors for late-stage disease and also help guide interventions, policy, and resources. So in summary, my goal as a global cancer researcher is to utilize implementation science to deliver effective and sustainable cancer control evidence-based interventions, to collect epi-data in order to monitor progress with the intent of observing downstaging of breast and cervical cancers with the goal to ultimately reduce global disparities in cancer mortality. So I just want to acknowledge all of the people that are involved in this. And as we all know, it takes a village. And so I just have great teams in Botswana, Tanzania, Nigeria, people from the global oncology community, and my mentors. And so thank you so much. I'm happy to take questions.
You hear some applause. You see some applause. Thank you, Tara.
Thank you.
It's a lot of work, and it's nicely described the sequence of thinking as you're working through that. We have applause, but anybody have comments and questions?
So I can start with your question about vaccines, the HPV vaccine. So while that prevention, the HPV vaccine has not been my area of focus, I know that there are a lot of studies working on it. Actually, I just read, they're moving to, I think, to help the implementation of vaccines in Sub-Saharan Africa. I think data has shown that a 1-dose vaccine could be effective, and this could help move it along. But again, the vaccine serves women 20, 26 or younger, and it's ideally for girls that are 9 to 14. And so in order to really reduce mortality for the generations now in the next few years, screening is important, but that's also why I think, the vaccine can help the future generations. The cervical cancer screening can help the now generations. And then also in the future, if we integrate this breast cancer screening as well, then we can start to battle the breast cancer that will probably rise as the age population shifts. And so we don't create disparities in breast cancer mortality. If this is all integrated, we can kind of move to what we need and kind of de-implement when it's no longer necessary.
Arnold, did you have something?
Yeah, I did. That was a great talk. What I'm hearing, your title talked about one size doesn't fit all, but what I'm hearing in the talk is actually a lot of commonalities in terms of principles and ways to approach things. And I'm wondering, sort of on a practical level, how do you identify, how do you go from identifying sort of common threads that you're seeing in these different locations to quickly, understanding how you can take that and individualize or contextualize into a specific place? Have you had examples of that as you've cut across? Because I'm really, again, as I say, I'm more struck by the common features than I am by the differences at least in terms of how you brought this out.
So thank you for that question. Actually, so this brings me to something that I really did just think of. I was just recently at the Dissemination Implementation Science Conference, and one of the big kind of topics that people kept bringing up is that implementation science is not generalizable. And so people want their results to be generalizable. But as you just said, I really thought about it, and I'm like, I really think we hit a saturation point where we do kind of understand all the barriers, and then we know the tools to fix them. But barriers, as I mentioned, Botswana and Tanzania. So Botswana has government-funded healthcare, so cost is not such a big barrier to them. They just need to get there. And so it can take over, I didn't mention it, but it can take over 16 hours for some people in rural areas to get to services. And so that is a big barrier that they have. Tanzania, on the other hand, cost is a very big barrier that we are finding with our patients, because they need to pay for everything upfront, particularly if they don't have health insurance, and approximately half the population doesn't. So I think, implementation science has, implementation science strategies that we use to implement things. And so I think, with this toolbox of strategies, we can see which ones do we need for this setting. And so where we may need to offer some financial assistance, in another country, we may need to, add another facility closer, to other parts of the population.
So Tara, on that step 5 that you saw in Tanzania, where the drop off of women that they did have a cancer diagnosis, but half did not get treated. Is that as far as you know? Could they have gotten treatment somewhere else? Or was there follow-up that they did not get treatment? And if they didn't get treatment, was cost a part of that? I'm asking 2 questions, I guess.
Yes. So I really appreciate that. So as I mentioned, we have started our patient navigation program. And so when we first looked at the data, we would really think that women did not receive treatment. Dar is another place where they could receive treatment, like Dar es Salaam, but that is much further away from Bugando. And so what we are really learning from qualitative interviews with our patients from the patient navigator program is that women do say, I don't have the money, I will come back. And our patient navigators are really trying to follow up with women who don't initiate treatment. And so they're really not initiating it. Additionally, the further women are the further they don't feel well. So it might be harder for them to come back if they're diagnosed at a late stage and then they feel sick. Additionally, there's a number of women that, as we know with a breast cancer diagnosis, you might not feel sick. And so they might not come back because they've seen other people go through chemotherapy and, that makes them sick. And so we do have patients that have talked about going to see traditional healers, which is also some work that I've done, but I didn't present here because can't talk about everything. But, in rural areas, a lot of women would go to traditional healers instead. And then just the last thing I'll mention, and it's been noted in Botswana with work by Dr. Yehuda Marte, that, a lot of these places, particularly in Tanzania, where the government is supposed to supply chemotherapy, but the woman comes back for chemotherapy and it's just not available. There are stockouts. And so then she will have to pay for it from Rwanda. And that's
Stefan, did you have a question?
Has been really clarified. The only thing, once more, going back to Botswana, thank you, Dr. Fribourg, interesting talk. The HIV connection with cervical cancer was of interest to me here. What's the rate of ART availability? Are all persons with HIV infection treated and managed properly? And how is their vaccine take then? Does it depend? The APV vaccine, I'm not sufficiently sure about its biology currently. Does it depend on the immune status of the HIV infected person to work well and be protective? That would be one thing. And then for Tanzania, obviously, you could make a study actually comparing a country where universal care apparently exists with one that doesn't. And it's a pity that Botswana still looks bad when it comes to distance, but I could imagine that Tanzania looks bad on top of that. And that point would be, I think, an important one to make, in terms of conclusion. Universal healthcare should be really a goal for everyone.
Yes, thank you for that. I really agree. To the first part of your question, so Botswana has actually done a great job with the 90-70-90 goals for HIV elimination. So I think at least 90% of the population with HIV has been identified, and a large proportion, I don't have these numbers off the top of my head, so forgive me, but 70 to 90% are on treatment. I believe 70% are on treatment, and I think the 90% goal was to have undetectable levels of HIV in their system. And so Botswana has done a really great job with HIV, and I think it also increases the problem of cervical cancer because we see cervical cancer occurring in women with HIV at much younger ages than we would see here in the United States. Women as young as 25, because the cancer seems to progress quicker. And I don't know if it's, what the biology, I don't believe is really known, but the compromised immune system, compacted by the HPV infection progresses, just seems quicker to cervical cancer. Also, actually, so the spore that I mentioned that Johns Hopkins is a part of is actually looking at an HPV vaccine in HIV infected women to see. I feel like right now the HPV vaccine is designed for younger girls. So ideally before they would get HPV infection or HIV infection. But the spore is looking at how effective is this vaccine in women, perhaps in their 20s or 30s, against cervical cancer. And so I don't know the answer to that. I think they're still, researching it. And then, I think, that would be a fantastic study to look at the two countries and to kind of, be a proponent for universal healthcare, as we know everywhere we could use universal healthcare.
Even here.
Thank you.
Yes, even in the United States. Thank you.
Other comments, questions? We even have a team member from Botswana on the line. Vusi Ndaba. I thought he might jump in, and the numbers in Botswana for HIV treatment coverage is actually the highest in the world, and it's was presented at the AIDS conference last summer of over 95% on all indicators, whether you're not just 90, 90, 90, but greater than 95%, greater than 95%, greater than 95% on those indicators. But that aside, any other comments, ideas?
Just a quick comment. So I noticed that you're focusing a lot on stage, like one of the cancer outcomes you have stage and mortality. But I was wondering why you're not focusing in receptor status, so triple negative in the case of breast cancer, because I imagine that the prevalence will be higher and is going to affect treatment and all of that. So is it because it's not available, or?
So that's a very good question. Yeah. So at Bugando Medical Center, there is not a lot of hormone receptor testing. So women don't know the status of their hormone receptors. Again, it's another thing that they have to pay for. And so if they're just going to have surgery to remove their breast cancer, which is usually the least expensive and first option, then previously they weren't even doing biopsies on it. And so they just, didn't pay for the extra. It's something that actually we've talked to our physicians about, and we try to get the hospital to help with. Another thing I've also heard, though, is that they give tamoxifen to everyone because it's very inexpensive and easy to give. And I don't know if this is true for Uganda. I've heard it from other settings that don't do hormone receptor testing, that they, just make tamoxifen available to all the patients because it's a very low cost, and it actually costs more to determine the receptors. But triple negative breast cancer, I've also done work looking at triple negative in Black women in the United States. And as I mentioned before, I did genetic research before, and so I am really interested in the future at looking at the genetics from women in Africa and women in the United States, and the differences in triple negative and aggressive disease. So yes, thank you for that question. I think it's a great one, and I think it's just unfortunate that they don't have all the tools that they need for the most appropriate care.
It sounds like that's a major disparity right there.
Yes, yeah, absolutely.
And also, if you look in this country stage for stage, triple negative disease, there is disparities. African Americans do worse. So, adjusting for economic, social issues, et cetera. So, biologically, it is likely a different disease.
Which I think I really do feel like, epidemiological data from Africa could, give us some insight into that kind of question.
Yeah, Fumi Alafati has done quite a bit of work, as in Nigeria. So, and that's been a passion, including inflammatory breast.
Yeah, Fumi and I worked together she was part of Simba as well. She's fantastic.
Yeah.
But yeah, has done a lot of work.
Great. Well, thank you so much. We're at the top of the hour, and Tara, thank you so much, and everyone here stayed all the way through. That's, I think, an indication of the interest and in your presentation and how it was presented, and the topic, which is overall key, and that's why we're also have as one of our focus areas of the disparities in cancer care and prevention in Africa. But thank you, and I just add another applause to
Thank you.
We really appreciate it.
Thank you so much for having me.
Great. And we'll see you soon, I hope. Yep.
Bye.
Bye, everybody.